Good evening, good afternoon, and good morning, and welcome to a global audience. I'm Nona Baker and have the honour to be co-chair of MPN Voice. A welcome to our webinar for parents of children and adolescents with an MPN. We're delighted and very excited to be collaborating with our French friends from Vivre, avec, and MP. This is the first webinar that we have done using AI avatars, which means that the clinical talks will be available in different languages. A very exciting development for both our organizations. On behalf of both organizations, I would really like to thank everyone who has made this possible. I know the teams involved have worked long and hard to make this happen. As a community, we're very, very grateful to you all. Thank you. I'm now going to introduce you to Karen Torrente-Leroux, who is the president of Vivre, avec, and MP.
Bonsoir, bienvenue dans cette première webconférence de l'année 2025. Donc, dans le cadre de notre programme Allo Hémato, cette première webconférence est donc le fruit d'une collaboration avec nos amis anglais de MPN Voice. On en a eu l'idée en septembre dernier autour d'un café en Pologne. Depuis, on a tous travaillé pour vous proposer aujourd'hui cette émission consacrée au NMP chez les enfants et les adolescents. Et nous avons la chance d'avoir aujourd'hui avec nous les professeurs Claire Harrison et Jean-Jacques Kiladjian et le docteur Juan Carlos Hernández-Boluda. Merci donc infiniment à tous les trois, ainsi qu'à l'équipe du professeur James Theo du King's College Hospital pour avoir permis de mettre l'intelligence artificielle aux manettes pour les traductions. Côté pratique, je vous rappelle qu'il ne faut pas prendre de capture d'écran de tout ce que vous allez voir, de ne pas les diffuser, ça serait vraiment très, très sympa de votre part. Et puis, vous allez rentrer dans une salle où vous allez avoir tout en français. Et puis, on se retrouvera pour un temps d'échange dans une salle commune. Donc, laissez-vous guider, vous allez voir, c'est assez intuitif. Et à tout à l'heure.
Thank you, Karen. And now I'm going to welcome Professor Claire Harrison, who will talk to us about the clinical talks.
Hello, everyone. It's a great pleasure to be here. I'm going to ask my colleagues to introduce themselves in a moment. I'm sure you all know them. They do a lot of work for MPN patients across the globe. And it's a huge privilege to be here with all of you this evening. So, Jean-Jacques, I wonder if you would like to say good evening.
Merci beaucoup, Claire. Merci à tous. Je suis très heureux de participer à cette webconférence. Donc, je m'appelle Jean-Jacques Kiladjian. Je travaille à l'hôpital Saint-Louis à Paris, en France, où je m'occupe plus particulièrement d'un centre intégré qui s'occupe des patients porteurs de néoplasie myéloproliférative. Et je vais vous parler aujourd'hui de généralité sur ces maladies et de génétique. Et je serai très heureux de répondre à vos questions avec mes collègues tout à l'heure.
Perfect. And Juan Carlos, I think you are in Valencia this evening, and perhaps you would be generous enough to say hello as well. Thank you so much.
Sí. Muchas gracias, Claire. Sí, estoy encantado aquí de participar en esta reunión con este formato tan especial, tan atractivo. En efecto, trabajo en el Hospital Clínico Universitario de Valencia y desde hace ya años me dedico a las enfermedades mieloproliferativas y también al trasplante. Y tengo el privilegio de ser el coordinador del subcomité de enfermedades mieloproliferativas de trasplante del Grupo Europeo. Y bueno, pues estoy encantado de poder aclarar cualquier duda después de nuestra ronda de presentaciones con vosotros.
Fantastic. And so you can see the topics that we will be speaking on, and one of us will be a genuine person in each film, and one of us will be an avatar, and the others will be avatars. We hope that this works well for you, and we look forward to interacting with all of you later.
Hello, everyone. Today I'm going to explain how myeloproliferative neoplasms develop. These are blood diseases, but what is our blood made of? You probably know this. There are cells in the blood that circulate in our bloodstream, and there are three main families of cells. First of all, there are red blood cells, which are essential because they transport oxygen from the lungs to all our organs, allowing all our organs to live and function properly. There are also small cells called platelets, which are responsible for clotting the blood. They will spring into action, for example, in the case of bleeding. If you cut yourself, it's the platelets that will come to plug the small vessels at first to stop the bleeding. And finally, the white blood cells. There are several types, but overall, all these cells, all these white blood cells, serve to defend us against infectious agents or against abnormal cells that may appear in our body. So all these cells that roam in the blood have a limited lifespan. A red blood cell, for example, lives on average for 3 months. A platelet lives roughly about a week. Some white blood cells only live for a few hours. So our body constantly needs to produce new blood cells to maintain normal functioning. And where does this happen? This happens in the bone marrow, not to be confused with the spinal cord, which is in our vertebral column and contains nerves. Here, the bone marrow is located at the center of the bones in our body, in all the bones. And in this bone marrow, we find what are called hematopoietic stem cells, which are like seeds that can give rise to all our blood cells, our red blood cells, our platelets, our white blood cells. Depending on the needs, these stem cells have two main properties: the birth of all our blood cells, our red blood cells, our platelets, our white blood cells. Depending on the needs, these stem cells have two main properties. They can proliferate, multiply, so that from one stem cell, they can produce several dozens or hundreds of final cells. And they can differentiate. That is to say, these unique stem cells will be able, depending on the needs, to transform or produce either red blood cells, platelets, or white blood cells. This happens under the influence of a number of proliferation factors or hormones. And if we take, for example, the case of red blood cells, let's imagine that you have fewer red blood cells in circulation, what we call anemia. The body will notice it and will produce a hormone, the famous erythropoietin or EPO. You know that some athletes use it as a form of doping. How does this EPO work? This EPO, which is produced when we lack red blood cells, will bind to the hematopoietic stem cells to send them a signal. And it says we need to make red blood cells, so this cell will multiply, will proliferate, and eventually produce red blood cells to normalize the number of blood cells in circulation. How does this work? Here you have a representation of the membrane of our stem cell, its outer wall, and here its nucleus with its genes. When our proliferation agent arrives here, in this case, erythropoietin will bind to the surface of this hematopoietic cell on what we call a specific receptor. This will lead to the activation of this receptor and a signaling cascade within the cell, which will go all the way to the nucleus of the cell to activate the genes that transform this cell into red blood cells. So to summarize, you're lacking red blood cells. Your body synthesizes EPO, which will bind to the hematopoietic stem cell and tell it to produce red blood cells. And as you can see in this diagram, a fundamental element of this signaling cascade, the first one, basically, activated by EPO, is an enzyme called JAK2. And we will, of course, talk a lot about it in myeloproliferative neoplasms. So, what happens in myeloproliferative neoplasms? In fact, there is an excess of proliferation. In myeloproliferative neoplasms, the bone marrow and our stem cells proliferate for no reason. We don't necessarily need to have red blood cells, but the hematopoietic stem cells, for example, in polycythemia vera, will produce red blood cells in a deregulated manner when there aren't any not necessarily needed, and this will lead to an excess of cells in the bloodstream. This is also the case in essential thrombocythemia, where the stem cell produces too many platelets. Even though we didn't ask for it, the baseline platelet count was normal. How do these anomalies, these excess proliferations occur? In fact, it's through mutations that occur within these blood cells, these hematopoietic stem cells. So these are mutations that we don't find, for example, in hair, in the skin, or in other cells, but only in hematopoietic stem cells and their results, so the blood cells. And there are three main mutations in myeloproliferative neoplasms. The most common one is the mutation of the enzyme known as a tyrosine kinase, JAK2, which we just talked about, and which is related to the receptors of these cytokines. On the opposite side of this slide, you see another receptor. So the receptor for another hormone called thrombopoietin, which is the hormone that helps produce platelets. This receptor is called MPL, and it can also be mutated, carrying a mutation that is obviously found more often in essential thrombocythemias. And finally, the third mutation, and the last one that was discovered, it's the mutation of the calreticulin gene, or CALR, which acts like a false regulator and will activate our receptors, notably the thrombopoietin receptor MPL, as if it had its ligand thrombopoietin, but it's an activated false regulator. So there are three main mutations in MPNs: JAK2, CALR, and MPL. These mutations will affect the bone marrow progenitors of blood cells. What we know is that they are acquired, meaning they are not congenital. They don't exist from the formation of the embryo, but they will appear in the cells during life. So these three mutations are not passed on to children in an hereditary way. They occur in every individual and will be responsible for a disease. However, they can occur and be detected long before the disease appears, sometimes decades before. And we now know that in some people, these mutations are acquired even in utero before birth. However, the disease will only develop several years later, sometimes decades later. They can be diagnosed and detected through a simple blood test, as we will analyze the cells circulating in the bloodstream. And we will see if they carry these three mutations or not. As you can see on this slide, these three mutations are found in MPNs, except that in polycythemia vera, there are almost only JAK2 mutations. We never find calreticulin or MPL mutations. On the other hand, in essential thrombocythemia and in primary myelofibrosis, we can find all three, but with different frequencies. As you can see in this table, for example, the JAK2 mutation is the most common in the three diseases, almost exclusively in primary polycythemia, and present in more than half of the patients with essential thrombocythemia or primary myelofibrosis. In these patients, the second most common mutation is that of calreticulin, which is found in 20 to 30% of patients. And finally, the rarest, the MPL mutations, which are found in about 5 to 10% of patients with myelofibrosis or essential thrombocythemia. What is the main and most dangerous consequence, at least at the beginning of the disease? This is what we call thrombosis, which is the formation of clots. In MPNs, you see that blood circulation will be affected because there are too many cells in the blood vessel. Unlike the normal situation here, there is a kind of bottleneck that will cause the blood circulation to slow down and will promote the formation of these clots, of these infamous thromboses. Moreover, the cells in MPNs are a bit overexcited. They are excessively activated, and so this will also contribute to the formation of clots. These clots can occur in any vessel, both veins and arteries. In the veins, this is what we call phlebitis, when it happens, for example, in a vein in the leg. In clots, it can obviously be more dangerous. It can affect the coronary arteries, for example. It causes heart attacks, the cerebral vessels, with the formation of strokes, the infamous strokes. So all these complications of thrombosis are what we obviously want to avoid. Once we've made the diagnosis, we reduce this excess of cells by various means that we will discuss later. There are also later developments that can occur, and these diseases can evolve into one another. For example, polycythemia or essential thrombocythemia can transform over time into myelofibrosis, with the appearance of fibrosis in the bone marrow. As we will see later, unfortunately in some cases, though less frequently, MPN can also evolve into more aggressive forms over time, such as acute leukemias, for example. Fortunately, this last transformation is rare, late, and we must do everything, of course, to prevent it. We mentioned earlier that these diseases are not hereditary and do not run in families. That's not entirely true, as there are in 5 to 10% of patients several cases of myeloproliferative neoplasms in the family defining familial forms. These familial forms are rarely explained through mutations of JAK2, MPL, or Calais. For example, as I mentioned earlier, these do not pass from parents to children. They appear within the cells once they are already formed. On the other hand, in rare cases for now, despite extensive research worldwide for years, we have almost never found these genes that are the source of these familial forms, except in a very specific case, which is found only in families from Martinique or Guadeloupe, where we discovered these somewhat unusual anomalies, ATG2B and GSKIP, which are related to genes located on chromosome number 14, so they are not related to sex. These are not the X and Y chromosomes found in men or women. Here it affects a chromosome that we call somatic normal, and these mutations, ATG2B and GSKIP, which are found only again in families with syndromes of myeloproliferative neoplasms, are responsible for all types. We can see thrombocythemias, myelofibroses, and polycythemias appearing with, however, a higher frequency of essential thrombocythemias. And these forms related to these mutations are generally more aggressive forms that will have a greater tendency to progress to more severe forms of diseases like acute leukemias or myelodysplastic syndromes. Here you see examples of 3 families. These are family trees. The small squares represent men and the circles represent women. And you can see that in these families, many members can be affected by a myeloproliferative neoplasm, whether it's essential thrombocythemia, polycythemia vera, myelofibrosis, or even acute leukemias. So, very specific case for which we found genetic anomalies, but in the vast majority of familial forms today, we have not yet found the mutations that cause these rare familial forms. And it's important to remember that most cases are what we call sporadic forms. That is to say, forms that occur by chance, but that do not get passed down in families from parents to children, at least not in a direct way. To conclude, myeloproliferative neoplasms are proliferation diseases that produce too many cells when we haven't asked them to. There is a lineage that generally predominates and allows us to classify these diseases. When it comes to red blood cells, it will be primary polycythemia or polycythemia vera. When it comes to platelets, for example, it will be essential thrombocythemia. Fortunately, as I showed you, we are starting to understand the mechanisms that lead to these diseases well, and this also opens up new therapeutic perspectives with the famous targeted therapies that will aim to target these different anomalies at the source of the disease. Thank you very much for your attention.
Hello everyone, my name's Claire Harrison. I work at Guy's and St Thomas's Hospitals in London, and I'm super happy to be with you today as we set out on this journey to try to learn more together. My job is to talk about what information we have and some current research concerning myeloproliferative neoplasms for young people. Now, we know that myeloproliferative neoplasms are rare in patients who are under the age of 25. In fact, a striking piece of information is that the occurrence of these conditions is approximately 100 times more for patients who are over 60 than those who are under 25. That doesn't mean, however, that we don't know anything about these conditions for young people. Before delving into some of the most recent information we have, I wanted to reflect that as a clinical community, we are aware that having these conditions, sometimes called cancers, in some countries
not quite referred to as cancers have several challenges for all of our patients. But particularly for young people, we feel that they are different for our older patients. There may be specific concerns around pregnancy, for being able to fulfill being a parent, sexual life, the ability to travel, more concerns perhaps about longer term effects of treatment, and concerns about how this diagnosis will impact their life. What I want to share with you today is some information from a study that Jean-Jacques Kiladjian, myself, and colleagues from elsewhere in France, Jean-Christophe Vianotto, and particularly Marta Sobas, have been leading on behalf of a group called the European Hematology Association, or EHA, MPN Special Working Group, or SWG. We set out some time ago when Jean-Christophe came from France to work with us at Guy's Hospital in London to explore what was known about patients being diagnosed under the age of 25. And we collected information across this group, which is a collaborative group of experts and people interested in MPNs. 46 clinicians were involved from 15 countries. And on the right-hand side of the slide, you can see the different countries and the number of patients that came from those countries. The main objectives were to describe the children and the young adult population in terms of their diagnosis and relevant outcomes. So, TFS means thrombosis-free survival, MFS means myelofibrosis-free survival, and overall survival, OS. And we also wanted to investigate the impact of treatment in terms of long-term events like thrombosis and myelofibrosis. The majority of these patients were ET and PV patients. We did not collect sufficient data to make clear recommendations about myelofibrosis patients. So when we take a look at this population, we can see that the youngest patient was less than 1, but that overall less than 4% of patients were less than 10 at the time of diagnosis. Median age at diagnosis was 20, and we had followed up these patients for some time by the time we included them into this data collection. So the age at the time we included data was 28 years in terms of the median. The youngest was 6 and the oldest was 60. So we had some patients with very long-term follow-up. Overall, you can see that the vast majority of our patients, 89% of them, had ET or PV. The other types of myeloproliferative neoplasms listed on the bottom of the slide were rarer, and therefore it's more difficult to say anything about these types of MPN in terms of this data collection. Here you can see a snapshot of the patients at the time of diagnosis. For example, their blood counts. And some differences in these parameters are shown on this slide as well. Here you can see, for example, that patients' platelet counts tended to be higher for ET patients than for PV patients, perhaps not surprising, and also that the hemoglobin tended to be higher for PV patients. Concerning symptoms of hyperviscosity, like headaches, were more common for patients with PV. An enlarged spleen and fatigue was also more common for PV, as was so-called aquagenic pruritus, which means itching when in contact with water. So overall, the PV patients tended to be more symptomatic. But when we think about what we call constitutional symptoms, such as weight loss, fever, night sweats. These were more common in patients with other MPN. And that is not surprising because these are part of the diagnostic criteria for these conditions. Now, let's take a look at the follow-up and what type of treatment these patients had. So overall, the median time of follow-up was just less than 10 years, and 40% of these patients had more than 10 years of follow-up. Most patients, as you can see, had antithrombotic drugs such as low-dose aspirin, and some patients were treated with phlebotomies, which is a common treatment for polycythemia vera. Concerning cytoreductive treatments, that's treatments to control the blood count, you can see in this slightly more complicated slide, first line, over 2/3 of these patients had a cytoreductive treatment. And you can see the type of treatment here in this graphic. 51% of these patients had hydroxycarbamide as a first treatment, and just over a quarter had either anagrelide or a further quarter interferon. And you can see the different types of treatment according to the different diagnosis, with more patients with ET having anagrelide and more patients with PV having interferon. In general, we observed that the use of these drugs was more common than we might predict following international guidelines. Now, what about vascular events? As you know, blood clotting and bleeding is more common in patients with MPN. Interestingly, we found that thrombosis occurred in about 10% of patients in the past and bleeding about 6%. Concerning new events after diagnosis, again, thrombosis was more common than hemorrhage, but only just. Most of the thrombotic events were venous, and recurrent events occurred in about 1/3 of patients. This is higher than we would expect in a population of patients that we would usually deem as being low risk. If you look at cumulative risk of thrombosis, this is something we describe medically. You can see in the chart the risk at 1 year, 5 years, and at 10 years. And you can see that this risk increases generally over time, and perhaps is more common for patients with polycythemia vera. But by all means, not all of the patients experienced a thrombosis. So this is what this graph on the right-hand side shows, that actually 70% of patients over time did not experience a thrombosis. We also are able to say that the risk of thrombosis doesn't particularly correlate with the type of MPN. Now, what about when we look at transformation events? So for one thing that was very striking here was that transformation events were mutually exclusive. So only one type of transformation event occurred for each patient. Most of the transformations occurred for patients either transforming from ET into PV. And this was generally occurring at around a 10-year time point. But the most common transformation event was into myelofibrosis, which appeared to be more prevalent for patients with ET if you look at these numbers. But remember, 70% of the patient population were ET patients. So actually, it was broadly the same between ET and PV. The occurrence of acute leukemia was rare for patients in this cohort, which is a good thing. We've recently asked a question: what is the impact of treatment upon transformation and also on thrombosis? I'm not showing you the information about what the impact of treatment is on thrombosis because we didn't find a strong impact. That doesn't mean that thrombosis is not reduced by treatment, but it just means that the number of events was quite small. Looking at transformation events, and specifically at MFS, which is myelofibrosis-free survival, we found that for patients treated with interferon, none of these patients developed myelofibrosis. And you can see that in this table on the left-hand side, 100% of the patients receiving interferon were free from myelofibrosis. And you can see the other types of treatments, hydroxyurea, anagrelide, or indeed no cytoreduction, and the risk of myelofibrosis with these treatments. This does not mean that we should be treating all patients with interferon, but it is telling us something about the impact of this treatment. Now, another important factor for young people is talking about having children. And I just want to share with you, before moving on to some information about pregnancy, the data that we collected as part of this study across the European group. Overall, we found 119 patients who experienced pregnancy. The live birth rate was 78%. This was mostly in patients with ET, and in fact, if you look at the whole medical literature, we know much more about ET in pregnancy than the other MPNs. 20% of patients were treated with a drug. Most of these patients were treated with interferon, which is what we would regard as a safe drug in pregnancy. Now, a few more words about pregnancy and contraception. Most forms of contraception for young people with MPN are fine, but any hormonal contraceptive containing estrogens, commonly called common or combined oral contraceptive pill, are not recommended. This is because of risk of thrombosis. Now, when we think about pregnancy, we would try to talk about this to all of our young patients with MPN. Obviously not the very young ones, but where we think it's appropriate. And specifically, we ask our patients to come to us if they're really thinking about pregnancy. And when we're doing that, we would counsel them about risks, which you've just seen. Generally, pregnancy is successful. We'd want to optimize control of their disease, control any other risk factors, for example, tell them to stop smoking. If they are on some drugs, specifically hydroxycarbamide, anagrelide, or ruxolitinib, we would want to switch in advance of pregnancy. And we would advise them, when you get pregnant, tell your team, follow standard advice. For example, take folic acid. If you have polycythemia vera, you are probably short of iron. And in pregnancy, we're very fond of giving people iron supplements, but we tell our patients, please not to take iron in pregnancy without talking to us. We would offer low-dose aspirin. A phlebotomy or venesection is okay. We might offer injections to reduce the risk of blood clotting, and we would regularly scan pregnancies. For patients where we think pregnancy is high risk, that would be if they'd had a clot before, for example, we would routinely offer interferon and a blood thinning injection, and we would do more pregnancy monitoring. After delivery, and we would usually recommend whatever the obstetrician believes is the best way to deliver the baby, we would usually give a low dose, low molecular weight heparin, which is this blood thinning injection, after the pregnancy for at least 6 weeks. An extra question usually arises, should the baby be tested for MPN? In general, we would say no, as the risk of inheritance of these conditions is low. Now, I want to close by saying, what should our plan be? Our plan B should be to publish, share, and talk about results, and we are publishing these results. We are also planning to collaborate, to pull together international guidelines, and we have invited patients to be part of this work, and we will be doing this across our European and international networks. We're I also feel it's really important to form a supportive network of young people and their families. And this webinar today is a culmination of this work, and I really hope that we continue to share information together in this kind of setting. So I'm super happy to be here today. I look forward to questions afterwards, and I'd like to thank you very much for your attention.
Good morning. My name is Juan Carlos Hernández-Boluda, and I am proud to say that I work at the Clinical University Hospital of Valencia, Spain. It's a pleasure for me to participate in this virtual meeting, which I'm recording, at the beginning of January. So I wish you all a very happy New Year 2025. My talk will focus on the role of transplantation in the management of myeloproliferative diseases and some new treatments. Surely this slide that Dr. Claire Harrison lent me has been shown before, and it represents the idea we currently have of these diseases as an evolutionary process in which some individuals develop certain genetic alterations that could lead to myeloproliferative diseases, what is called clonal hematopoiesis, and how the expansion of these genetic alterations, along with the emergence of new alterations, conditions the onset of thrombocythemia or polycythemia vera. Eventually, the progression to myelofibrosis, and very rarely the evolution to acute leukemia. In recent years, there have been very significant advances in the field of myeloproliferative diseases. There is a much better understanding of the cause that leads to these diseases. There has been a significant advancement in the characterization of risk groups, meaning identifying which individuals are at higher risk of developing thrombosis, or progressing to myelofibrosis, or eventually having leukemia. And there have been very significant advances in treatments, mainly in preventing vascular complications and also in controlling symptoms. There isn't a completely optimal treatment, but there have been significant advances in the last, let's say, 10-15 years. However, there are still some areas where we are struggling to improve outcomes, and it is fundamentally in the detection or enrichment of the potential progression of these diseases and in the development of curative treatments. And in this sense, it's definitely important to target those pathways, those mechanisms that are involved in allowing malignant cells to be viable and survive. We need to attack them from different angles, and we can also use targets with what are called immunotherapy therapies through antibodies or vaccines that can specifically target some particular antigens present on the surface of neoplastic cells. This is a very complex slide. It shows what a cell from a patient with myeloproliferative disease looks like and the surface of that cell. It simply illustrates the number of treatments being researched. 2. Target the viability of these cells that have abnormal growth and can harm us. I will quickly show some of these treatments in the second part of the presentation. First, I would like to talk about hematopoietic stem cell transplantation, which is a procedure that is currently not used in thrombocythemia and polycythemia vera. It is used in aggressive myelofibrosis, and it is a procedure known to be curative. It is really the only curative treatment of myelofibrosis to this day, and this is known because there are many patients who have undergone transplantation in recent decades, as this image shows, and they are alive. They have been cured of their disease. However, It is a procedure that is used in a subgroup of people with myeloproliferative diseases, no more than about 10%, and I'm talking about adult patients over 18 years old, because in the case of it's used very little in children and adolescents. However, it is a procedure, as I said, aggressive, and therefore only people with a very high-risk disease are selected. I'm going to mention, so you have a little bit of knowledge about what it consists of, some aspects in a very superficial way. The first thing you need is a source of progenitor cells from a donor, and this source can be obtained from bone marrow, peripheral blood, or cord blood. Currently, we mainly use peripheral blood, meaning it's like a dialysis machine that collects stem cells from the potential donor. Most patients can now have a donor. Without 100% compatibility, 50% compatibility, like from parents to children, is enough for a successful transplant. Currently, with a 50% compatibility, for example, from parents to children, the transplant can be performed successfully. And this would be the outline of the transplant. First, we would have the cells that appear with R for the recipient, meaning the patient, and once we ensure that we have the donor's cells, we admit the patient. We give chemotherapy. Basically, it will kill the cells of myelofibrosis, but also the healthy cells. Therefore, we have to give the recipient the donor's cells, and eventually, in the following weeks, at first, there may be a coexistence of cells from both the recipient and the donor. But for the transplant to be successful, in the end, all the cells need to be healthy cells from the donor. And here it can happen that those cells attack the myelofibrosis, which is what usually happens, but they can also attack the graft versus host, and they can also attack the recipient. And this is the fundamental problem of the transplant, this lack of specificity in the donor's immune system, which can lead to these manifestations. In the skin that we have here, which is an attack of the donor's cells on the tissues, in this case, the skin of the recipient. And also during this period, the patient is immunosuppressed and may have opportunistic infections like pneumonia, or may experience adverse effects from the chemotherapy. However, despite all these problems, the age of the patients who undergo the transplant is increasing. And these are data from the European Transplant Registry, from the MMT, which is growing more and more. And in fact, now we dare to transplant people who are even over 65 or 70 years old, because we use transplant procedures that are more tailored to the patient's age. You can see here that the number of patients, these are all adult patients, over 18 years old, but there are very few patients in youth who undergo transplants. Recently, tried to address this lack of information about transplants in children or adolescents with myelofibrosis. This work from the European Transplant Group was published, and notice that over a period of 22 years, this is a retrospective study. Information could only be gathered from just 35 cases. That is to say, few patients, children and adolescents, with myelofibrosis undergo transplantation. And the conclusion of the work was basically that the procedure was successful with a higher likelihood than in adults with this disease. What we do to establish the indication for transplantation is something similar to what is shown here in this figure. First, we assess the risk of myelofibrosis. The risk of myelofibrosis is how aggressive that disease is. How is it going to cut the life expectancy of a certain person? And we determine those patients who have less than 5 years, and I'm talking again about adults, of being alive. It's the median survival. Not necessarily all the patients we select as high risk will die within 5 years. Not at all, but they have a high probability of doing so. Once we have selected those individuals, we need to calculate the transplant risk to try to balance the risk and benefit of the procedure. And to explain this, obviously, to the patient in a language suitable for making a shared decision. For this, we use what are called prognostic models. This is one of the most commonly used to define the risk of the disease. It's called MIP70. We're not going to go into the variables they use, but disease characteristics, genetic characteristics, and it discriminates risk groups. And those who, let's say, are doing worse with medical treatment could be candidates for a transplant if they have a good overall condition. And then we can estimate the probability of transplant success, also based on a series of characteristics of the patient, of the disease, the type of donor, to finally reach a decision in which we have the two risks of the disease and the transplant. And we can discuss this risk balance with the patient, and not necessarily. In many cases, the transplant is an urgent decision in myelofibrosis, but it can be postponed. In this second part of the presentation, I'm going to briefly discuss some of the advances in the management of these diseases. I'll start with essential thrombocythemia, and this is the treatment algorithm that is generally used for this disease. There are some additional nuances, but, well, this serves to exemplify to a large extent how we work. A population of high-risk patients with thrombocythemia are those who are over 60 years old or have had a thrombosis. That's high risk. The rest are low risk. In all cases, we control cardiovascular risk factors, that is to say, hypertension, smoking, diabetes, and increased cholesterol. And if there are no contraindications, we generally give low doses of aspirin. But for high-risk individuals, it's recommended to undergo cytoreductive treatment to better control the blood count parameters. Basically, the rise in platelets that occurs in this disease. And we mainly have these three cytoreductive agents: hydroxyurea, anagrelide, and interferon. And in this regard, one of the medications that is being tested and could be interesting to incorporate into our treatment arsenal is bovenenstat. It's a new molecule that has shown a good tolerability profile in clinical trials. Incorporating into our treatment arsenal is bovenenstat. It's a new molecule that, in clinical trials, has shown a good tolerability profile, as well as good control of platelet and leukocyte counts. It's a new molecule that, in clinical trials, has shown a good tolerability profile, and thus a good control of the platelet and leukocyte counts, without generally causing anemia. This medication is being compared to the standard treatment to see if it plays any role in this disease. The treatment algorithm for polycythemia vera is similar. Here, what we often see is an increase in platelets, but above all, there's an increase in the number of red blood cells, what is called hematocrit. We define that high-risk population. Again, it's also age over 60 years or having had a thrombosis. In all cases, we control cardiovascular risk factors and give low doses of aspirin. In low-risk patients, we control the hematocrit, mainly with what we call phlebotomies. The patient has blood drawn periodically, as if it were a donation, but that blood is discarded. And for high-risk patients, cytoreductive treatment. And here we commonly use hydroxyurea or hydroxycarbamide and interferon and ruxolitinib. But is there any new drug in clinical trials? For example, rusfertide? Rusfertide is an interesting molecule because under normal conditions there's a molecule that we produce in our body called exidina. That exidina closes the transfer of iron from macrophages to red blood cells. That is to say, if it is not produced, that transfer of iron cannot be made in red blood cells. This happens in situations of inflammation. So rusfertide would be an analog, a molecule similar to exidina, in such a way that it would close this transfer and then block the production of red blood cells. And it has been seen in clinical trials that people who need phlebotomies because they have high hematocrit, they have polycythemia vera when this molecule is administered subcutaneously, it stops needing phlebotomies. The red dots would indicate the need to draw blood, and in the green part, when the medication is being received, you can see how this slows down the transfer of iron to the red blood cells, and it doesn't happen. An interesting molecule that is in advanced clinical trials. Interferon has been used for many years, but its use has increased. Importantly, especially in some countries where we didn't use it much, like for example in Spain. Perhaps due to the poor tolerability of the old formulations of interferon, but now the pegylated forms, or the ropage interferon that appears here, are better tolerated on one hand. And on the other hand, there have been studies that took a long time to get results, because sometimes in these diseases you need many years to see some complications of the disease. And what has been seen in these clinical trial studies is that interferons are the drugs that allow for molecular responses in a greater proportion of patients. And there are already some studies with long follow-up. This study provides evidence that suggests a significant possibility that these sustained and lasting positive responses to interferon treatment could potentially play a role in reducing the risk of disease progression over time, where it shows that perhaps these lasting responses to interferon could even reduce the risk of disease progression. In this case, polycythemia vera and myelofibrosis. Regarding myelofibrosis, I've already talked about transplantation for high-risk individuals who are in generally suitable condition. But most patients with myelofibrosis receive medical treatment. Here, thrombosis is a problem, but there are others. And fundamentally, it is a more symptomatic disease, and many people have anemia, lose weight, and experience discomfort related to an enlarged spleen. Treatment in regular clinical practice focuses on the patient's symptoms. Generally, for anemia, we have some effective treatments like erythropoietin, and for the symptoms, the most useful medications that have been introduced are the so-called JAK inhibitors. JAK is a target whose activation causes a lot of what we call cellular proliferation and symptoms. What advances have we seen in recent years? What we call cellular proliferation and symptoms. What advances have we seen in recent years? Well, there is a signaling pathway that is inside the cells called the family. TGC-beta? Well, you just need to know the details, but simply that this pathway influences the onset of some symptoms of this disease, even perhaps in the development of fibrosis, so that if one blocks it, they can control symptoms and improve anemia. From the patients, there are already several medications being used, and this pathway is being blocked with very interesting results. For example, luspatercept, which is an antibody that blocks some ligands that would stimulate this signaling pathway. Well, it's useful for the anemia of this disease and is in the clinical trial phase. Also, in advanced phases of clinical trials, we have also incorporated JAK inhibitors very recently because we have ruxolitinib, which was approved in Europe by the regulatory agency in 2012, but notice that in 2021, fedratinib was approved, and last year, momelotinib was approved. In addition, this molecule is of interest because it controls constitutional symptoms, but it also improves the anemia of the patients. And another one is being tested, pacritinib, which is approved in the United States. Not in Europe yet, but we can use it in clinical trials. And it's an interesting drug for people who have very low platelet counts. So this is also an advance. And then to wrap up, many effective drugs are being combined. For example, the combination of ruxolitinib with other molecules. Here we have pelabresib, with the idea of achieving deeper responses, not only to better control the spleen, which is the case, but to increase the percentage of people who reduce the mutational burden or decrease the fibrosis in the bone marrow. And this is a field of great activity in fibrosis, and every year we go to conferences looking for updated information on these drugs. Some treatments called immunotherapies have also been incorporated, mainly antibodies. In the field of biopharmaceuticals, we're moving a bit slower than in other diseases because these diseases do not express on the surface anything that distinguishes them from normal cells. And this is essential for making a targeted treatment. But for example, the mutated reticulin can indeed be targeted and attacked with antibodies. And we are investigating this in clinical trials. So I've talked about some of these molecules throughout my presentation, but as you can see, there are many others. It's a rapidly evolving field, and fortunately, I believe we will have new drugs for the treatment of these diseases. And I'm done. With these three conclusions, I want to say that as of today, Transplantation is the only curative treatment for myelofibrosis, but we need to carefully select which patients should be candidates for this procedure. That there are multiple drugs in clinical trial phase, and some may have the potential to delay this progression of the disease, which is something that is quite important. And research in this field, fortunately, is very important, and I believe we can take pride in that. There are numerous drugs and a lot of laboratory research aimed at trying to improve the outcomes, and we will surely see great advances soon. And with that, I'll leave it.
I'm now delighted to welcome Alice, a young patient who's been inspirational in starting a young person's Facebook page, which now has over 330 followers and a social gathering. But she's also with her mum, Pam, and they are going to give us a talk about how they felt about the diagnosis of an MPN and give us some tips. Welcome, Alice, and welcome, Pam, and thank you for your contribution.
Hello, my name is Pam. I live in England and I have a daughter, Alice, who has an MPN.
Hello, my name is Alice. I have JAK2 positive ET, and we're really happy to be speaking to you today about our experiences. So the structure of our talk is as follows. We're going to start with a brief overview of our story. We're then going to move into an interactive Q&A in which we each ask each other some questions. And then finally, we're going to finish by each giving 3 top tips for parents of children and adolescents with an MPN. So we're going to start with our story.
Alice has a long history of suffering from migraines with aura. She started having migraines when she was 9, and for many years it had a significant impact on her life at school and at university, and also our home life.
Yeah, so I had migraines all through school, through my GCSEs and A-levels, and I eventually went to university, and unfortunately they continued there. They were regular and debilitating. I couldn't even walk up 3 flights of stairs to my lecture theatre without triggering a migraine attack, and so I decided to see a new GP in my new university town, and he listened to my story and he just said to me, Alice, this isn't right for a 20-year-old. I'm going to do a series of blood tests, which he did. Each time they came back with a slightly elevated platelet count in the 500s, and that led him to do a JAK2 test. And this was all happening while I was doing my university exams, so I had no idea what was going on.
In the background, I started to do research about JAK2 positive diagnosis and what this might mean, and this led me to finding out about MPNs.
And so I returned home after my exams. This is just before Christmas, and my mum had found somebody locally who was an MPN specialist. And the day after my 21st birthday, we had that appointment, and indeed I was diagnosed with an MPN. It was a really upsetting time. They didn't at that time know whether my migraines were related to my MPN, but I was started on clopidogrel, which is an alternative to aspirin.
Given the uncertainty of Alice's diagnosis of whether it was ET or PV, I did more online research and found that in the UK, Professor Harrison was one of the leading experts. So we asked our GP locally if we could have a referral to Guy's Hospital.
And that was really because of the diagnosis uncertainty, but also the rarity of MPNs in young people. So we found that Guy's was a centre which was specialising in MPN, but also potentially had other young people from across the country there. And so I find myself at Guy's. I had a series of tests which confirmed I had ET and not PV. And I felt really lucky to be at Guy's under the care of Professor Harrison and her team, who are an expertise, and also had lots of other young people there. So I didn't feel so alone. And thankfully, by taking clopidogrel for ET, I went from having regular migraine attacks to virtually no migraines at all.
This was a big change to our lives, finding that migraine was a symptom of a MPN. And also, as we met more young people with MPNs, we discovered that many of them suffered from migraine as well. So it was very interesting for us.
And we think it's probably likely that I've had an MPN for much longer, you know, potentially even from the age of 9 when my migraines started. But fast forward to now, I'm still on watch and wait. My platelet count's in the 600 to 700, so it's risen slightly over that time. And I take clopidogrel also in combination with aspirin now. I started that a few years ago to try and reduce my symptom burden. I get visual disturbances, head pain, fatigue. And I have found that adding aspirin has helped a bit, but I still would say that ET does have a big impact on my life. And I take amitriptyline as well to manage neuropathic pain in my head, which started during the COVID-19 pandemic.
So we're now at a time where it's a balance between Alice managing her symptoms and also thinking about, you know, when it'll be the best time to start treatment, and maybe that would help with relieving some of the symptom burden.
I think that's a real challenge, isn't it? Knowing when's the right time for intervention, especially when there's been some conversation around, do you take something like interferon to potentially prevent you transforming to a different type of MPN? So it's really difficult to know when that right time is, but I'm still just taking clopidogrel and aspirin. And I've adopted lots of self-help measures as well to try and manage my symptoms on a day-to-day basis. So that's things like keeping to a regular sleep pattern, taking a daily walk. I adopt an anti-inflammatory diet, drinking lots of water to stay hydrated. So it's really a case of managing it and living with this new normal of having an MPN. So we're now going to segue into a Q&A where we each ask each other some questions, which we hope you'll find interesting. So maybe I'll start by asking you the first question, which was, what was your biggest worry at the time of my diagnosis?
The biggest worry at the time of diagnosis was that we knew so little about MPNs. We didn't even really know anything about blood cancer. Also, it was the question of when might this transform into something else, another MPN or indeed leukemia. And I think the main thing we worried about was what does this mean in terms of life expectancy, and it was a very worrying time. So my question for Alice is, the first question is, how did you navigate turning 21 and discovering you had an MPN?
Yeah, I would really just echo everything you've said there about how scary it was at that time. You know, it's always a big milestone to turn 21, and I feel looking back, it was totally overshadowed by that appointment and being told that I had a blood cancer. That word obviously has particular connotations, and you're thinking, how do I fit into this with a kind of chronic blood cancer that doesn't quite fit that diagnosis, treatment, cure cycle that that you hear about. So on the one hand, it was a terrible time. But on the other hand, you know, it gave me a new lease of life because managing my MPN through clopidogrel stopped those debilitating migraines. And so I had a lot to be thankful for of getting that diagnosis. So my second question for you is, after being diagnosed with ET, did you do any further research about MPNs, and how helpful did you find those resources that you came across?
I think it's fair to say that I'm constantly doing research and reading up on MPNs. The MPN charity has been a wonderful resource for accessing information on MPNs, and I also do consult Patient Power in the US, which has also provided a lot of helpful information. So my question for Alice is, how valuable have you found it to connect with other young people and indeed be part of the MPN Voice community?
Yeah, I found it absolutely invaluable. You know, I can still remember that very first in-person patient forum that we went to, where I met another young patient, and I'm still in contact with him today, and it's just been invaluable to connect with him and other young people, you know, sharing our stories to diagnosis, our worries and concerns, helpful resources that we've come across, you know, sharing links with each other. And it really just combats that isolation of diagnosis, and you realize you're not going through it alone, and that there are people out there who are navigating the same journey that you are. So my final question is, what would you say the biggest challenges of caring for a daughter with an MPN?
I think the biggest challenge is that it's the unpredictability of the symptom burden, in that Alice will go through periods where, you know, her health is better, and we get used to her in that kind of mode, and then she'll have a bad period, and it's the unpredictability of her health that is, you know, quite a challenge to sort of manage. And so my last question is, Alice, how do you cope with the uncertainty of the disease and the and what the future might hold?
Yeah, so I would say it's changed over time, you know, thinking back to that period directly after diagnosis, you know, the uncertainty was overwhelming, really, you know, not knowing how long I would have ET for, whether it could transform to something else more acute. But over time that's lessened, and I think practicing mindfulness, you hear about trying to stay in the moment, which is obviously, you know, something you do minute by minute. It's not easy, but that uncertainty and worry has lessened over time. There are certain periods when it becomes more acute if you're going through a difficult patch with symptoms and so on. But doing some small things like living healthily by going for a walk, eating healthily, feels like you have some agency. It can be difficult sometimes being branded as watch and wait, that you feel like you're a ticking time bomb waiting for something to change. But those things can help you feel like you have more control, and maybe even delay or prevent transformation in the future. So we're going to finish now by each sharing 3 top tips that we've thought of for parents of children and adolescents with an MPN. So maybe I'll go first and say that my first tip would be to be an advocate for your child. You know your child best. If you think that you're not getting the best care, that the specialists you're seeing, maybe they don't specialize in an MPN, they're a hematologist more broadly, don't be dissuaded from seeking a second opinion and finding the right clinical team that delivers the best care for your daughter or son.
My top tip is to be patient with the unpredictability of symptoms, and recognise that you have to sometimes, adapt your plans accordingly.
My second tip would be to recognise that every young patient processes and comes to terms with their diagnosis differently and at different speeds. They may not want to talk about it with you or look at information that you've found at that particular time, and I think it's important to respect that and recognise that they'll come to you when they feel ready to talk about it.
My second tip would be that it's worthwhile thinking about ensuring that your daughter or son gets some kind of disability support plan at university or college, or indeed in the workplace, so that reasonable adjustments can be made to make their life slightly easier.
And my final tip is to be a source of understanding and support, you know, helping your child to navigate key developmental milestones like starting school or starting college, going to university, thinking about a particular career path, you know, really helping them navigate those things with this added challenge of processing a cancer diagnosis and managing a chronic disease day to day.
And I think my final tip is to really think carefully about joining some kind of patient group or charity, because it is not only helpful for your son or daughter, but for you as a parent as well. And it's an ongoing sort of learning process that a patient group, you know, can help with. So thank you very much for listening to us, and I hope you found some of it helpful.
Yes, thank you for listening.
Bye-bye.
Bye.
A huge thank you to both Pam and Alice. A truly inspirational talk from them both. I might just also add that they, a couple of years ago now, they had published the MPN Voice Recipe Book, which is available on Amazon. And that book has got a lot of anti-inflammatory recipes and is a really good resource for MPN patients. It's now time for me to hand over to the clinicians, Claire, Jean-Jacques and Juan Carlos, who are going to answer questions. And we'll start with Claire. Thank you.
Well, thank you very much, and huge thanks again. That was a wonderful video, Alice and Mom. I really enjoyed that. I learnt a lot. So we had a series of questions that were submitted, and actually it is still possible to put questions in the chat and we will try to answer them for you. Probably I will speak only in English because my Spanish and my French is not so good, but my colleagues may speak in whatever language they like, of course. So I've tried to group the questions that were submitted at the beginning, and we'll try to pick any up in the chat. But Juan Carlos, I think we all discussed a little bit about this context of cancer or not cancer, but maybe you could say whether in Spain MPN is regarded as a cancer or not.
Thank you, Claire. Yeah, I mean, you all know that these diseases are considered blood cancers according to the World Health Organization, and we tend to call them blood cancers in Spain as well. But as Pam has brilliantly explained, actually they are quite different from what we think about a normal cancer, because the clinical features and also the genetic features are very stable over the decades. Even we have to say that our treatment is mainly prevention of vascular complications, not treatment of the disease, which is completely, curious in a cancer. So I would say, even if we name these diseases blood cancers, their behavior is completely different.
Thank you so much. That was a great answer. Now, thinking about treatments then, maybe I could ask you, Jean-Jacques, we all touched a little bit on treatment, but perhaps I could ask you about, there was a question about whether even just a small blood clot would be an indication for treatment.
C'est une très bonne question. Je dirais qu'il n'y a pas vraiment de petits caillots. Bien sûr, les caillots vont avoir des conséquences différentes suivant l'endroit où ils se produisent, et un caillot dans la circulation du cerveau va avoir beaucoup plus d'impact qu'un caillot dans la jambe, par exemple. Mais du point de vue de nos maladies et de leur traitement, le fait de faire un caillot, où qu'il soit, indique qu'il y a un risque d'en refaire un autre plus tard ailleurs, et donc impose en général que l'on commence un traitement pour faire diminuer les chiffres des cellules sanguines d'une part, en association bien sûr avec un traitement anticoagulant qui lui va prendre en charge le caillot en lui-même. Mais quel que soit le caillot, quelle que soit sa localisation, en général c'est une indication à commencer un traitement.
Perfect. Thank you so much. And I'm so pleased that the translation is working well for me, and I hope it is working well for everyone else who's listening as well. So maybe I have to give myself a question now. And the question is actually a really good one. It's a couple of questions about specifically the platelet count. And the question is a few questions. One, does exercise affect the platelet count? And is there a best time of the day to take the test? And does the platelet count correlate with the amount of a mutation, or otherwise known as VAF, or variant allele frequency, or allele burden? So I think that normal exercise, such as you or I might do, unless you really do some very crazy exercise, should not really affect the platelet count. And it doesn't, as far as I know, but maybe my colleagues will correct me, vary much during the day. But there are some other things that can affect the platelet count for patients, such as drugs. Obviously, we use drugs to control the platelet count, but some other medications may interact or lower the platelet count. An infection may push the platelet count up, and very relevant for patients with polycythemia vera, iron deficiency, such as induced by removing blood or phlebotomy, can also raise the platelet count. Now, about the VAF, or the quantity of mutation, I think it's difficult to answer directly whether that's really affected by, affects the platelet count, but diseases can look a little bit different according to the type of mutation. So Juan Carlos, there's a question for you now about CALR mutated ET. And the question is really specific. What about the use of aspirin for CALR mutated ET? So maybe you could start the question by talking about why we know that aspirin is important, especially for JAK2 disease, and then some differences with CALR. And of course, it's fine to speak in Spanish if you wish.
No, it's fine to talk in English because in our we were very few people in the Spanish box, so I think it's better to talk in English, make the effort. Now, yeah, in several studies in Europe and also in Spain, we have tried to see the balance of using aspirin in different genotypes or different MPNs with the different mutations. So you all know that aspirin is very good in preventing thrombotic complications and also in treating microvascular symptoms, such as the ones that Pam has told us about the migraine and this headache and these sort of things. So the general recommendations to use aspirin in the majority of the patients, but what we saw with the calreticulin patients is that here the thrombotic risk is very low, especially if there are not concomitant thrombotic vascular risk factors or not symptoms. And you have also some slight increase in the bleeding risk. So for these patients without vascular risk factors, having a calreticulin mutation ET, we do not recommend in general the use of aspirin because of this balance of bleeding and thrombotic prevention. Is it clear? I don't know, Claire, if
Yes, I think it's very clear, and I think that you know, some of us might still use aspirin, some of us might not. In my practice, I sometimes would still use it because maybe the patient in front of me also has diabetes, for example, or already had a blood clot. So, but we are a little bit more worried, exactly as you said, quite rightly, you know, that there may be a bit more bleeding with CALR mutated patients. Jean-Jacques, any thoughts from you on this?
No, I agree. I think we have this balance between symptoms. Some symptoms are very sensitive to aspirin, and in some patients that aspirin is very useful. In others, according to these mutations, sometimes you may induce more bleeding than benefit. So yes, this has to be balanced and assessed with the patient after starting aspirin, I think.
Okay, perfect. Now, a question for you, maybe a couple of questions actually. Of course, you are the person who in the world has really pushed forward the field with regard to interferon. And this is really a big impact for us and for patients. So I wondered though, if you could talk about what do we know about the indication for interferon? You know, should we just use for everyone, or should we only use for high risk patients? I'd say this is really a big question of our time. And then maybe what do we know about long-term impact of interferon, especially for children?
Complicated questions. Thank you very much.
Yes, you're welcome, but you're more than capable to answer them.
Okay. Certainly not every patient should receive interferon. There are some clear contraindications, especially psychiatric or psychological contraindications, autoimmune diseases, etc. So there's a series of contraindications, obviously, that in which we should not use interferon. Then I think we have a balance. Interferon has more visible adverse events or adverse effects, reactions than hydroxyurea, for example. So if your aim is to maybe reduce this famous allele burden you mentioned before, meaning that you look at a very long-term endpoint with these diseases, of course, yes, you have to start first interferon and then adapt your treatment. If the aim is more to control the symptoms, avoid the clots we mentioned, then hydroxyurea may be also a very good option. So it really depends on each patient's profile. Age can be one of the characteristics, and we are discussing more about young patients here. So clearly in younger patients, you want to have a more deep impact on the long term. So you will first start maybe interferon. In older patients where you want to be safe and not harm, not induce adverse events, you will maybe prefer hydroxyurea. So yes, I would say, why not try interferon if there's no contraindication, and if the tolerance is not good, then switch to hydroxyurea, because you may first see these benefits on the long term. On the other hand, you ask for long-term toxicity. I would say that usually what we see in terms of adverse reaction to interferon is mainly at the beginning of the treatment. And after 1 or 2 years of treatment, usually we don't see any new toxicity and there's nothing really new happening. So the tolerance is quite easily assessed within the first couple or 6 months after starting treatment. And once you pass this, you don't see more adverse events than what you see at the beginning.
Maybe I could just try to answer a question about long-term risks of anticoagulation, if I understood one of the questions that's put in the chat. So actually, the long-term risk of anticoagulation is really related to bleeding events. Some of our newer anticoagulants, known as DOACs or NOACs, such as edoxaban or rivaroxaban, they are very new, but there's very little reason to believe that they are not so safe. Now, a little bit random in terms of the question to you, Juan Carlos. I want to ask about monitoring for progression and how should we monitor for progression?
Sí, bueno, un primer concepto que yo creo que es importante en estos tiempos es que las visitas periódicas en persona son importantes, aunque se pueda hacer alguna visita telefónica, pero que las visitas en persona son muy importantes, porque en gran medida en las entrevistas, en lo que te dice el paciente y en la exploración física, ver si ha crecido el bazo o no, ahí ya tienes unas claras señales de si la enfermedad está estable o no. Y luego con los parámetros del hemograma tienes muchísima información. Yo creo que la mayor parte de la información acerca de la estabilidad de la enfermedad viene sencillamente de estas pruebas sencillas. Ver al paciente, hablar, explorarle la barriga y un hemograma, sin necesidad de ecografías, tags, biopsias de médula ósea ni nada de esto. Y luego hay una segunda parte que son los estudios genéticos o moleculares, que yo diría que están más en el campo de la investigación en general, pero que sin duda nosotros que estamos en centros de referencia, pues tendemos a utilizarlos más porque nos pueden dar algunas pistas, ¿no? Cualquier elevación o descenso significativo de la carga alélica de la mutación, driver o conductora, puede tener correlación con lo que le puede pasar a esta persona o lo que estamos viendo en el hemograma, ¿no? O la aparición de algunas alteraciones genéticas adicionales que no estaban al principio, ¿no? Nos pueden servir de alarma, ¿no? Pero las dos primeras, lo digo porque en gran medida, pues muchos de vosotros estáis seguidos de esta forma, hemograma, exploración física y anamnesis, es suficiente, ¿no?
Great. And may I just ask about mutation testing and how often do you think that mutation testing is important? And is a change in the amount of mutation important?
Sin duda, los tendemos a utilizar mucho más. Con respecto a las mutaciones driver o conductoras, nuestra tendencia ahora es, cuando pensamos que hay un tratamiento capaz de reducir la carga alélica, como ha comentado Jean-Jacques, el interferón sería el prototipo de este tipo de tratamientos, hacemos una determinación cuantitativa basal y luego anualmente para ver si hay un descenso o no. Y la técnica, digamos, más de los últimos años, que son los estudios de secuenciación masiva o NGS, Next Generation Sequencing, particularmente en pacientes jóvenes, tendemos a hacer estudios iniciales, basales, para hacernos una idea del perfil genético global. Y estos en general, si no hay ningún cambio clínico, no se suelen repetir, ¿no? Por lo menos en la inmensa mayoría de los pacientes.
Jean-Jacques, could you comment about the role of testing for mutations? And then I see a question, I think, in the chat about, does interferon also work for calreticulin positive disease?
Oui, alors nous aussi, on suit la mutation en la mesurant, pas juste si elle est présente ou pas, mais en mesurant la quantité de mutation dans le sang, environ une fois par an ou tous les 2 ans, quand il n'y a pas de signe particulier qui évoque un changement de la maladie, juste pour voir ce qui se passe et si celle-ci augmente ou diminue au fil du temps, notamment avec les différents traitements qu'on peut proposer. Et excuse-moi Claire, j'ai oublié la deuxième partie de la question.
I can't remember. Oh yes, does interferon work for calreticulin positive disease? Yeah.
Merci, pardon. Oui, nous avons montré que l'interféron pouvait également diminuer la quantité de mutation calréticuline, mais c'est beaucoup plus long et plus difficile en général que la mutation JAK2. Et il n'y a pas, dans notre expérience, de vraie corrélation entre la diminution de la quantité de mutation calréticuline et l'évolution clinique de la maladie au jour d'aujourd'hui. Donc c'est un petit peu plus compliqué, je pense, avec la mutation calréticuline, mais on peut aussi observer une diminution avec l'interféron de toutes les mutations connues, JAK2, calréticuline ou MPL.
Great. And I like asking questions because I get to ask all the difficult ones to my lovely colleagues. Juan Carlos, just to come back to you, do you think there's good evidence that any of our current treatments affect progression of disease? Because I know this is something that we worry about most, and it's something that we worry about a lot for our young patients, but we also do worry about long-term effects of treatment.
Sí, sí, sí. Bueno, esa es la gran pregunta, ¿no? El Holy Grail, ¿no? Eso es lo. Yo creo que tenemos muy buenos tratamientos para el control de síntomas y prevención de complicaciones, pero para detener la prevención de la enfermedad, esto es lo crucial y tenemos poco, ¿no? Yo creo que los únicos datos de algún fármaco que puede facilitarlo es el interferón. Claro, se requiere mucho tiempo de seguimiento para poder evidenciar este efecto y realmente se han necesitado estudios de varias décadas de seguimiento para poder tener los primeros datos, ¿no? Pero yo creo que el interferón sí que puede ser un agente capaz de esto, ¿no? Eh, en base a la disminución de la carga alélica mutada, que si bien en estas enfermedades puede haber otros subclones o otras pequeñas poblaciones de células que tengan esta alteración, que a lo mejor también son reducidas por el interferón, pero constituye la clona fundamental, ¿no? Pero bueno, también todos nosotros estamos participando en muchos ensayos clínicos con combinaciones de fármacos que son prometedoras. Lo que pasa es que los datos siempre son muy iniciales, a veces los ensayos clínicos no tienen suficiente seguimiento, se hacen a muy corto plazo y ya veremos, ¿no? Pero desde luego, sin duda, para la próxima década este es el objetivo a cumplir, ¿no? Detener la progresión de estas enfermedades, ¿no?
Okay, perfect. I totally agree with everything you've said there, and you speak very wisely about this. And Jean-Jacques, I think there's another question about additional mutations. Maybe we can ask you that question, and then we'll probably move to close the questions at this point. Yeah.
Oui, absolument. Il y a une question demandant si les patients qui ont une très faible charge allélique de la mutation JAK2, par exemple, est-ce que ça veut dire qu'il y a d'autres mutations cachées derrière? Alors, c'est une bonne question. Effectivement, chez quelques patients qui ont une très, très, très petite quantité de mutations JAK2 qu'on retrouve parfois chez des sujets normaux, notamment chez des patients, enfin chez pas des non-malades, des gens dans la population générale, on peut retrouver des toutes petites quantités de mutations de JAK2 par exemple, et qui n'expliquent pas forcément la maladie. Et parfois, effectivement, on retrouve d'autres mutations par des techniques qui testent un grand panel de mutations et pas simplement les 3 principales. Donc on a ces techniques maintenant qui, sur une prise de sang, permettent de détecter 40, 50 mutations différentes, qui vont parfois nous aider pour le diagnostic, nous servir également comme point de suivi comme pour les autres mutations, et certaines vont aussi nous indiquer une maladie plus à risque ou moins à risque d'évoluer rapidement vers des formes plus agressives comme la myélofibrose. Donc oui, c'est un test qu'il est utile maintenant de demander car il apporte des informations importantes.
Okay, that's perfect. Thank you very much. Now, I would like to thank everyone for answering these questions and my colleagues for doing such a great job. But in closing this medical question and answer, I want to come to each of you and ask you, what is your hope and excitement for the future for MPN? And I'll come first to you, Juan Carlos, and then to you, Jean-Jacques. And maybe you could also include some closing comments from you each, because you've both made such a big contribution to this webinar. So, Juan Carlos.
Muchas gracias, Claire. Bueno, mira, yo espero que en los próximos años se fortalezca un poco la inmunoterapia para los pacientes con mutación de calreticulina, bien sea con los anticuerpos específicos, bien sea con algún CART, que también había alguna pregunta al respecto de esto, ¿no? Yo creo que esto lo veo a corto plazo. Y también creo que vamos a disponer de combinaciones que van a dar algunas pequeñas señales de que somos capaces de disminuir la clona mutada. Y en qué medida esto tendrá un impacto en la progresión de la enfermedad lo veremos. Yo soy ahí, digamos, más reticente de que vaya a haber grandes avances a corto plazo. Pero bueno, esto es un poco como lo veo ahora mismo.
And any closing remarks from you, Juan Carlos, about this webinar? Thank you so much for being.
Bueno,
Yeah.
Claire, pues me ha parecido una webinar súper interesante, súper entretenida con este modelo verdaderamente paneuropea o global y he estado encantado de participar con vosotros. Muchas gracias.
Thank you so much. I'm really grateful to you because I know you gave a lot of time to sort out the avatar, etc. Jean-Jacques?
Yes, oui, pardon, en français pour que la traduction
Oui,
soit
en
correcte.
français, s'il vous plaît.
Merci. Comme Juan Carlos, je suis très excité des rebondissements qu'on attend avec les immunothérapies, mais qui va concerner effectivement les patients, le groupe de patients avec mutation calréticuline et pas tous les patients. On a aussi, pour les patients avec la mutation de JAK2, des traitements maintenant qui vont être spécifiques de la mutation de JAK2 qui s'appelle V617F, puisque les anti-JAK2 que nous avons actuellement bloque le JAK2 normal comme le JAK2 muté. Et peut-être qu'en ayant des médicaments qui vont bloquer uniquement le JAK2 muté en épargnant le JAK2 normal, on aura moins d'effets indésirables d'une part et peut-être aussi des traitements qui seront plus actifs sur le long terme pour éradiquer la maladie. En gros, on attend encore ces traitements potentiellement curatifs, mais c'est vrai qu'on fait de grands progrès déjà pour les traitements qu'on a actuellement et je pense que on a de grandes perspectives à venir dans les prochaines années, j'espère, pour les patients. Et pour conclure aussi, j'ai été ravi de participer à ce webinaire. Merci beaucoup aux deux associations qui l'ont organisé avec l'énorme travail que ça représente. Un peu de frustration parce qu'on aimerait toujours continuer plus longtemps ces discussions et répondre à plus de questions, mais je pense qu'on aura probablement, j'espère, d'autres occasions. Merci Claire d'avoir mené comme chef d'orchestre ce webinaire d'une manière fantastique comme d'habitude.
You think I conduct? I don't think so. I just take the opportunity to ask my colleagues the more difficult questions. So I am very optimistic for the future for these diseases. Working in this field for more than 20, maybe let's say 25 years, I see big changes for our patients. I'm hopeful also for the therapies that both of you mentioned, CALR and JAK2 targeted therapies, but I'm also hopeful of learning more about biology. And we do that by collaborating globally, ourselves, clinicians, scientists, patients, but also pharmaceutical companies. And I think we do that really well in the MPN field. I'm also super hopeful of technology, and we saw some amazing technology this evening with each of us speaking in different languages. So I want to thank everyone who's been involved. A special shout out as well to Alice and Pam. That was an amazing conversation between the two of you, and to the whole teams who've been involved in the background. So from the medical team now, thank you so much, and to pass over to the people who've been doing the real work behind the scenes. Thank you.
Karen would be talking about this, but this is a wonderful little book which you can get on Amazon, and it really does explain to children and their families what an MPN is. It's now available in French and English and soon to be published in both Spanish and German. Please follow the link below and then you will be able to get a copy. I highly, highly recommend it. Now, if you've enjoyed this webinar, which I think has been just amazing, and you know, as Claire's just said about technology, being able to hear presentations in different languages, it has just been one of the most informative and great webinars that we've done. You know, we'd be very grateful if you would support us, and if you feel that you can, please visit our Just Giving page and give us a donation. That will help keeping these kind of webinars and forums going. Also, we would be really, really grateful for your feedback because it just helps us in planning for the future. But in truth, I owe a lot to my friend and colleague, that little cup of coffee in Warsaw, Karen. Never did we dream that this would happen. And I have to thank everybody, all the clinicians and everybody in the background. Too many to name, but they know who they are. I'm really, really grateful to you, and I look forward to working with our French friends again. Thank you.
Alors,
I think
moi, je vais très rapidement vous rappeler qu'il y a ce petit livre en français qui est donc « Dis maman, c'est quoi une ENMP ?» Ça vous permettra d'expliquer à vos enfants, petits-enfants, mais aussi quelquefois à vos conjoints qui ne comprennent rien ou qui ne veulent pas comprendre, parfois on ne sait jamais. Et puis, je voulais surtout remercier Nona, Maz, Charlie, toute l'équipe géniale de MNP Voice et puis tous les médecins. Voilà, c'était génial. Et puis, que vous dire d'autre? Eh bien, merci. Voilà, je crois que ça veut tout dire. Et puis, prenez soin de vous, prenons soin de nous, médecins compris, parce que nous, on a besoin de médecins qui soient en forme. Je vous souhaite une délicieuse soirée et j'espère à très bientôt.